So, in good morning. Today in talk show, Dr. Narmadha from Vellore is invited to talk on allergies. She is MBBS, MRCPA, FRCPH, FIAP, DAA, lot of qualification with hospital administration MBA. She is a consultant pediatrician, affiliation to Nalam Medical Center and Hospital, faculty CMC Vellore, currently Honorary Secretary IIP Tamil Nadu, State Chapter, Vice President North Zone, IMA Tamil Nadu. Presently State Secretary IIP, lot of achievement she has received in all these years. Presently State Secretary of IIP, TN State Chapter, Core Committee Member, Editor Enrich ECHG CIP 2023, Central EB Member twice 2019 and 2020. Joint National Coordinator RTI JAM Module 2020, Co-Organizing Secretary Dakshin Pedican 2020, State Treasurer IIP Tamil Nadu State Chapter 27 and 18, Founder Member in IIP National Women Wing South Zone 2016, Organizing Secretary South Pedican 2015, Formal Editor State Bulletin IIPTN SC 2014. So many achievements, and we are proud to have her on Dr. Tuteja talk show today. She has a main interest is asthma, allergy, and immunology. 20 publication to her credit in national and international journals, served as editor and associate editor for various books. Proudly, we welcome you and start your presentation, please.
Sir, it's a very proud honor and privilege to be in your talk show, sir. And I've heard many interesting talk shows, and today I'm really privileged to be here. So I thought we will discuss a little bit of the basics of allergy for an office practitioner, how he should approach the same. So the main thing is we have to understand why do we need to know the allergies and what is the immunological basis, what are the commonest type of allergic disorders we are encountering in our practice, and how do we manage them as an office practitioners and not. So here if you can see that the 25% of the Indian population are suffering at least from one allergic disease. And in fact, it has been increasing in incidence that most of our practice from the infectious basis, the major non-communicable diseases has become asthma and allergic rhinitis together. And many people have atopic asthma because we are basically pediatricians and we deal more with atopic children. And 3.3% of the children in the age group of 6 to 7 years and 5.6% they have allergic rhinoconjunctivitis, pure allergic rhinoconjunctivitis alone. So this is a huge socio-economic burden. If you can see in the Western countries, though they say the incidence is coming down, the morbidity in India caused due to the untreated allergic disorder is very high. The loss of school days is more. They lead on to, they do not take the medicines properly. So acute asthma or an acute episodes are more common. And there is an unrecognized anaphylactic disorders also that is very common in our places now. So having said that, this is the kind of an allergic disorders that has come in a review article. If you could see, the incidence is more in the Andhra Pradesh, Orissa, and all that, as well as in Tamil Nadu. Overall, the other states do have a prevalence of 1,000 to 1,099, but still it is high compared to the 1 lakh population. And how much of these children are getting into the practitioners? You know, it is a very, and we always say, yeah, it comes and goes, and quite a 1 month or two twice episode is okay for all the parents, but then the problems that it is creating into the system, no, we don't. And a child having a sleeping obstructive sleep apnea because of that, not able to concentrate in the school, and a continuous allergic rhinitis, having an effusion in the ear leading to hearing disorders, a child continuously scratching and getting a secondary infection due to atopic dermatitis, and the mothers are not able to feed their children properly. They have severe lifestyle limitation. ये बंद कर दो, वो बंद कर दो, tomato don't give, brinjal don't give, don't eat ice cream, don't go to swimming. There is a lot of restriction. Already children don't eat anything, and the nutrition is very imbalanced, and because of this there is a lot of lifestyle limitations. So we don't they are afraid to even go and mingle with the other children, and parents are not allowing them to go outside. So there is a heavy impact on the children's life, which we as a practitioner should understand the basic of the Allah. That time only we can tell what to help them, how to help them out. Having said that, what is the definition of allergy? We need to understand that it is an abnormal reaction to an ordinarily harmless substance, that you and I may not react at all, but the children are reacting. There is another component called as a sensitization, sir. This is a sensitization is an immunological phenomenon. Some people will get IgE positivity, say for example to tomato or a brinjal. If they will do some test and that will show an IgE. But when you ask about their history, they will say that they have never experienced allergy after eating, that they have been normal. Or they will say that I ate this food 3 days before and today I am having an allergic problem. So that is not allergy at all. So you have something called as an IgE and non-IgE mediated. When you look, this IgE is predominantly the atopic. When you are sensitized, if you have allergy means, then you will develop reaction within about 2 hours of exposure to that particular allergen. Say you have eaten something and you become allergic, it's just within the 2 hours. Suppose you show only IgE positivity and you do not have the reaction within 2 hours, that is not an allergy at all. So we need to know this correlation. We have to ask them like what really happens. The temporal relationship is very important for us to understand first the allergy here. And as I said, there are this self-induction, immune tolerance to self. Whenever this goes for a toss, when this balance is lost, is when we get the allergy and autoimmune response. So we do have the innate immunity where we recognize ourselves and able to know and restrict only the foreigners, and to our own antigen we have a tolerance level, and this is imbalanced here. And generally when we are exposed to any foreign antigen, we get an infection, we develop a Th1 type of immunity. And sometimes when we are getting the allergy, what is the inflammation is Th2 and Th17. In a country where we are talking about hygiene hypothesis or the Western lifestyle, what really happens is there is a less incidence of an infection. So the Th1 is not activated, and we tend to develop more of Th2 immunity. In our natural process, if you look at, all of us will have only Th2. Only when we have the infection, we are developing Th1. In India, when we are living in a rural area, living with a lot of siblings in a family condition, we are exposed to several of the organisms. So children automatically have a good amount of Th1 immunity. So the allergic response was less and we developed less of Th2. But what is happening now, we are going to a nuclear family. Our children are also getting into an AC or this thing. Their food is also very, westernized. At that time, we have more of the Th2 immunity. Now, in an environment where there is more of environmental pollution and smoking, there is a tendency to develop more of Th17 immunity also, that also contributes to the allergic disorder. So this is a new understanding that has come up with regard to the allergic disorder. Why I need to understand all this is, I need to understand that here it is type 1 is what I'm talking about, and type 2, type 3 are not the allergic reaction which we are talking here. And we are predominantly concentrating in type 1, which is IgE mediated. Here there is a sensitization reaction occurring where the allergen that enters sits on the mast cells, and then once the mast cells are stimulated, they release all the allergens. And what happens during the clinical phenomenon is second exposure leads to an increase in the inflammatory signals that leads to a greater production of eosinophils and mast cells, and you need this gating of this epsilon receptor here. So sensitization is a must, and that comes to an innate substance which we normally don't react, and it is coming out here. So this is the basic of the allergic reaction, which is the early phase. You have the allergen specific IgE. They create the cross linking and they're sitting there. And once you expose yourself to the allergen the next time, there is a severe activation of these Fc epsilon receptors that leads to an inflammatory component that in the nose can lead on to an allergic rhinitis, in the eye can lead on to conjunctivitis, and in the airways it can lead on to a bronchoconstriction. You should always understand this concept in order to approach an allergy as a multi-system phenomenon. And whenever a child comes with one system manifestation, we need to ask, is there other systems involved? Is he sleeping well at night? Is he having any allergic rash? Because a parent will not understand a child who is having an asthma, the rhinitis or a conjunctivitis is a component or it's a united airways. He will go to an ophthalmologist for the conjunctivitis problem, an ENT for the rhinitis, and you will be treating him for asthma, and you will be wondering why it is not getting controlled, because the other symptoms have not got controlled. So this is the reason why we need to understand why it is a multi-system manifestation. Having said that, you have some everybody living in the same family, but some children develop a lot of allergic reaction, even among the twins. One of them, same viral infection, one will get wheezing, the one will not develop wheezing. So there are multiple factors. It is not only the genetic predisposition, it is not the environmental trigger alone. It is also exposed to the microbiomes, the viral infection, the pollution, the smoking atmosphere, all are dancing in together in order to produce an allergic disorders. This will actually help you when you're talking to a parent about why one child is developing some allergic disorder and why the other child has not developed this one. So we need to understand that allergic disorders are always multisystemic, get to know the entire system and ask symptoms with regard to this. And there is a lot of insistence with regard to the allergic march. This is nothing but the same phenomenon. A child who is having an allergic disorder as a newborn will the sensitization has occurred to the skin, and as he grows, it starts involving the other symptoms of allergic rhinitis or an asthma, and then he goes on to become an adult wheezer. Because there is a genetic predisposition, the environmental triggers are going to be there in this thing that is leading on to this problem. With this basis, let us see about 3 cases which comes in our office practice every time. So we have one child who has, she's a 9-year-old. She had a wheezing symptom as a toddler. She had been started on inhaler at the age of 1. The mother remembers she also had an itchy skin. Her predominant complaint now is a cold. So this is a very typical scenario which we will get. A child who is very well brought up and coming for immunization will slowly have the atopic dermatitis, just showing us we would have given a moisturizing solution. Then by about 9 months or 10 months, she'll start to become a wheezer, coming to you a lot of time. And then they will have a lull period for about 3 years. And again, by 9 years, they will have allergic rhinitis. So the examination will have a typical allergic phases. We need to look up whether there is allergic shyness. We have the post-nasal drip, the child is sleeping properly and all that. So the mother has been doctor shopping, going to a different doctors. So as an office practitioner, what you can do next? So she is worried about multiple things, whether the symptoms will progress, whether she will remain lifelong like this. And the symptoms are so varied. Started with the skin, gone on to the rhinitis, and now here. She is also having a younger sister, and she does not want to give the inhaler for a long time. So for us, we'll have to understand that it is an atopic nature, it is persistent, it is becoming progressive. We will have to understand that there are certain allergens which is activating here. So we will have to tell them that this child belong to a particular factors. We were using like viral trigger wheezers, multi-trigger wheezers, late onset and all that. But now we are going on to the phenomenon of a very personalized medicine. We'll have to classify these children according to a phenotypic nature and the cluster classification. See, we clearly know this child is an atopic dermatitis with a childhood onset asthma with a persistent allergic rhinitis now. So the mother needs answer. What is the problem? What is happening with my child? Where is the Nemo here, which is triggering all this? We will have to tell. And so what we can do in our practice is to prove that there is a type 2 inflammation, look at the allergens, maybe suggest them the environmental modification of the same. As an office practitioner, we will be doing a complete blood count and total IgE, but this will just tell that you're having a eosinophilia and total IgE is high. And in an Indian scenario, we know that there are a lot of reasons for eosinophils and absolute total IgE to be elevated. So this alone cannot be taken as a reason for the allergic disorder. So what I can give more is something like an allergy skin testing, which can be done with an adequate training. And in place you do not have the training, there are a lot of labs which are available now that look at serum specific IgE. So the allergy skin testing is what we understand that it is very clinically relevant, because you are sitting there, you are looking at the skin reaction, the parents are looking at this skin reaction, you are putting the drop of the allergen that you think are the reason and the parents think are the reason for the symptoms. They look at it, they understand what is happening in the skin is same thing that is happening in the systemic reasons for the child. So they are able to correlate it with the clinical symptoms, and it just takes about 15 minutes. You have an internal standardization using a positive and a negative control, and then you have the history sitting there that time itself you can correlate and immediately tell them that, see, your child is sensitized and there is a clinical history that is telling them that reaction is there within 2 hours. So the child, you can suggest an environmental modification. Quite often they will think about food, but we'll have to reorient them. It is not the food, it is actually the house dust mite, the cockroaches, the pets, which may be the trigger factor. And most commonly in India, the house dust mite and the cockroach, which they will not think. A child who is an allergic person will be sitting on a sofa which is having a lot of house dust mite. He will eat the food, go and sleep in the night. For the food in the sofa, the cockroach will come, leave its pellets, it will leave the skin and go. The next day, again, the child will be exposed to the same. So in infancy only, food allergy can be a manifestation, and the quite common thing is a milk. But generally, by about 6 months to 9 months and all, the food allergy comes down, and more of an aeroallergen sensitization kicks in. So this is the dust mite that is commonly there in the carpets and upholstered furniture. And we have a very different varieties of the antigens, which I will not go for want of time, because I just wanted to give a broad overview of the same. We will have to think about the silent culprit, the cockroaches. And the pollen allergens is only 15 to 20% in India, but they have a seasonal exacerbations, and you can clearly correlate with the monsoon onset. A child who had a very basic symptoms like an allergic rhinitis will suddenly have an acute exacerbation. So these are the commonest allergen that is found in India, and India is so diverse from the north to the south. But predominantly, if you can see in the south, it is the prosopis or the weed or the shrubs and the casuarina. And when you go along the north, you can see more of this oak and the citrus variety that is contributing to this. The Kerala has got more of Cocos nucifera, and we have this Parthenium and Cannabis sativa, which is there throughout. The ornamental plants like Amaranthus are also contributing in India. This is the predominant pollen, but area-specific variations is also there. You can see the sorghum mostly in the Punjab place where it is the predominant allergen, and cynodon and dicanthum, which is there in all the parts, which is a grass shear. So the cat is a predominant allergen. The dogs are not very much an allergen here. So we have a specific allergens screening panel where we test. And for a younger child, we do a very specific ones where we ask the history. We find out whether it is a seasonal variation or a perennial variation. And in the house, then if it is more, then we test only for a dust mite and the sensitivity. We have a positive negative control, which is the histamine, which is always reacting to everybody. antibody, and you have the saline, which is a negative control. If the child is reacting to saline, her baseline reactivity itself is high, we will not proceed with the reaction. So now doing this, we understand that it is an atopic nature. We are able to tell the parent what the child is allergic to, give her some environmental modification, change her lifestyles, look at other symptoms also. Having said that, the allergies testing will indicate our sensitization. We need to correlate it with the history. I already told you we need to have a specific history for the same. Sometimes we may get only sensitization in 42% patient. 8 to 30%, there may be a non-consistent sensitization and no history correlation. You have to sit and find it out with them. So this will not help us diagnose asthma, but it is a complementary to asthma and allergic rhinitis, where it helps us to control the environmental modification. Now, coming to a case snippet 2 is a 2-year-old child who attended a birthday party. He has symptoms when he was given the cake, he suddenly developed anaphylaxis, child fall down, he had an urticarial rash. He is a known asthmatic and he's already been on inhaler and also had an atopic dermatitis. With all this, he has a widespread eczema and rhinorrhea. In this patient, you cannot do an allergic testing. You know for sure this is an atopic nature. You know for sure it has involved multiple systems, but you cannot do an allergic system as testing. And the mother wants to know what are the allergens here. So then what I can do here, I could do something called as a serum specific IgE. So here I had looked at the point multi-system manifestation, allergic march. There is an evidence of anaphylaxis. So food allergy may be there. Skin testing is not possible. So what I do is a serum specific IgE. So this is different from the total IgE. I look at only the specific IgE for this. So initially it was a RAST type radioallergen. You had an allergen and you put in the incubated along with the patient serum where the antibody to that particular allergen was there. You tagged that antibody and found a quantitative method. But there was a lot of there was no correlation between clinical history and it was not very specific. So now we have the latest machine, which is the immunocap, that is found in our country now and it is available in most of the places. See, it is using an activated cellulose sponge. The sensitivity of the IgE has increased. Of course, the cost is very high. Similar to allergic skin test, you should not order a panel. You should correlate it with the history, order for the specific antigen, then again sit with the parents to find a clinical correlation. At this time, you will be able to find it out much better and the reports are given like this. So depending on the amount, you can also make a quantitative analysis and teach the parents about the environmental modification. Sometimes in food allergy, it will come as positive like this, but you have heard children either collapsing with the peanuts and some children will be able to take peanuts but they will have only an urticaria. Similarly, in milk, they will have only urticaria. They will not understand anaphylaxis. They will not get anaphylaxis. But certain children, when they just even touch a milk a little bit also, they will go on to develop anaphylaxis. Why is it so? When you have this, when you show a peanut sensitivity here, the mother is very worried whether he will develop anaphylaxis. At that time, this component result diagnostic is one important investigation that has come up now available in India, where I'm able to understand the allergens into a more specific proteins. And you have certain type of a specific protein that makes the children more prone for anaphylaxis, and you will be able to tell the parents accordingly. So coming to our case, we noted that this child had specific allergen to IgE, to egg, and he was asked to avoid that continuously. And he was also given the adrenaline injector because he was a child who developed anaphylaxis. We'll have to teach them. And in India, we do not have the auto injector, but still we can give the 1 ml needle and the adrenaline, ask them to use whenever it is essential. So in the case snippet 3, sometimes you have an urticaria which is not related at all to the IgE. Similarly, in this case, when there is an appendicitis, the child developed anaphylaxis. They all with and also had an urticarial. So this is not an IgE. It might be due to the latex sensitivity. Do not have the skin testing. What do? You'd have something called as a serum tryptase level. When you are in a doubt whether you are dealing with an allergic reaction or it is a non-IgE or non-allergic, serum tryptase level helps us to understand understand better, and now it has become more available in our India. So initially we were all telling that allergy is more of a clinical manifestation. Yes, we did have that, but we have to understand the allergic disorders, and there are also certain tests in order to help us to understand this allergies better and help our parents to do the environmental modification and give an answers to our parents. And also the management of the allergic disorder has changed, where we are going on for immunotherapy very earlier, and the cases which are non-IgE mediated, we start them on other modality of treatment, including biologicals like omalusipab in cases of a chronic urticaria, which has almost changed the life of the patients. So in conclusion, the management of the allergic disorder will involve the type. We have to understand it is a multi-system manifestation. What are the organs involved? What are the type of the offending in allergens? Suggest certain lifestyle modification. Start pharmacotherapy earlier because it is a progressive disorder. You know where to intervene, so they will not end up in having a final, some basic changes in the system, in organs itself. So we need to stop the disease progression. We have advanced modalities of treatment now, which can become a major game changer. Thank you so much, sir. I so hope I stuck with my time, and I thank you for giving the opportunity to talk on this interesting topic, which is close to my heart.
Thank you so much, Namitaji. It was very enlightening talk, and I am sure that all the IIP members and the public will be enlightened with this talk, and they will take care in their office practice. And when they are talking about allergies in pedicons and everywhere in the state and uh, local branches, they will take the advantage of this talk, and that will help to them in many ways. Thank you so much
Thank you,
being
sir.
with us.
Thanks for the opportunity,
Yeah,
sir.
thank you. Thank you. I stop the recording here.